And a lot's changed in the last 6 months, and we're going to try to go over that. And I've incorporated into my presentation many of your questions, but then I'll be more than happy to take questions as we go on. You can blow through the next slide, which is just a picture of me.
Oops. 1 second here.
Nobody wants to see. You can skip through that. So just briefly again, if we remember, we talked a little bit about the coronavirus when we first had this presentation in the summer. You know, the coronavirus is actually the same virus that causes the common cold, which is fine because it's a nice benign cold virus. But unfortunately, when it mutates, we get the bad viruses that come out. And we've had 3 what we call novel coronaviruses: SARS, MERS, and COVID-19. And now we have known variants. And as a matter of fact, this slide is already outdated, as we have the UK variant, the South African variant, and the Brazilian variant. Fortunately, we haven't seen many of the South African or Brazilian in the United States. However, as we'll talk in a little bit, the UK variant is widespread in the United States and will be the dominant strain here probably within the next few weeks. You can go to the next slide. So look at what's happened just in the last 8 months since I last started to talk about this. So Gilda's Club asked me in June, said, "Hey, would you think about doing this?" And I put together some slides, and looking back here, look where we were in June and look where we are now. And when you look at this, you can kind of get a little depressed and a little down. And I'm going to tell you to not get to that point and to really don't worry about what's happened in the past, because we've made a lot of advancements and we're turning the corner. And I'm hoping that this presentation is more uplifting than to share with you the data. But really, when you look at the numbers, you can see the impact that this disease has had on the United States, on Illinois, and really globally when you look at it. But when you look down at the bottom too, in June, we had just a couple of vaccines in phase 3 clinical trials, but now we've got 2 that have been approved here in the United States. 2 more will be approved here shortly, and 42 million vaccines, probably over 45 million vaccines by the time that I'm done speaking tonight. So you can go to the next slide. So we've learned a lot since we talked last. You know, when we talked last, we didn't have a lot of treatment options that we had, but now we can use monoclonal antibodies. But we know that, boy, at the time we were talking in the past, we were just collecting that data and we're using it on hospitalized patients. We found out now that no, we should use those in patients prior to being in the hospital. Remdesivir, we all heard about. It didn't turn out to be the blockbuster drug, but it certainly has an impact. And we also know, if you remember, in the spring, we were talking about running out of ventilators and we won't have enough ventilators. And yet here in the fall, we hit numbers that were double the high as the high in the spring. And yet we heard nothing about ventilators, and I'll explain why. And then also we look at the importance of looking at more than just the pneumonia part of COVID, because it causes other problems, including blood clots and some of the treatments that we've learned that have really saved a lot of lives. You can go to the next slide. But I was saying, be optimistic at this point. You know, everything is getting much closer. The light at the end of the tunnel is no longer a train, it's now sunlight. Look what's going on. Hospitalizations are down 20% in the last 2 weeks. Total cases are down 30%. Illinois cases are down 4 weeks in a row. We have 7 vaccines that are approved. We have more people that have been vaccinated than have had the illness. So now vaccine production, if you watch the news tonight, vaccine production has been streamlined. Johnson & Johnson, as well as Pfizer, has cut their production time. So by the end of June, we should have 300 million vaccines. We know that there's a lot of emotion around vaccines right now, and I'm going to go through the vaccines and just try to explain to you kind of where they are, because I know many of you are saying, which vaccine should I take? And as an oncology patient, should I be taking the vaccine? So you can go to the next slide. So the current options that we have right now, many of you probably heard, Pfizer and Moderna. Both came out pretty much at the same time, within a couple weeks of each other. Both of them have very effective rates, close to 95% effective rates, which has been great. And those were over the novel strain. We'll touch a little bit about what's going to happen with the variants, but really overall, we found great success with these two vaccines so far. The side effect profile that we're all concerned about, because we had a lot that was exposed during the trial, is really not panning out. Certainly, we're getting some people with fevers, with body aches, but really it's short-lived and really has not hit the numbers that it did in the data in the clinical trial. And that's what we call clinical trial bias, where we're asking everybody the next day, do you have any of these symptoms? Versus many of the symptoms that we have for these, people aren't even noticing. So the Pfizer vaccine, we do have some one issue with it. You need a freezer that can keep that vaccine at minus 90 degrees. So hospitals like Central DuPage and Northwestern and Rush and University of Chicago, certainly they have those freezers. But most hospitals don't have those freezers because they're really used for research. So that has really limited who can get the Pfizer vaccine, because once it is reconstituted, it has to be used within hours. Moderna, on the other hand, again, great vaccine, can be put in a regular refrigerator, and the two shots are 28 days apart instead of 21. If you ask me which of these two currently I would add, it's a coin toss. I think that really the side effect profiles are the same. You're going to see that both of them are effective against the UK variant, which we'll talk about in a little bit. And they are a little bit effective against the South African variant, but not as much as we really need to be. So I can tell you that both Pfizer and Moderna are looking at a booster to cover for the South African variant. You can go to the next slide, we'll talk about the future. So if you look at the vaccines in the future, you probably heard last week that Johnson & Johnson asked for an emergency use authorization, meaning that they're going to try to get their vaccine through before a full FDA approval. Exactly what Pfizer and Moderna did. And what's happening now is that their data on over 30,000 people is being studied. Many people are very optimistic about the Johnson & Johnson vaccine for a couple reasons. One, it's a single dose. That is key, because right now, doing the logistics of making sure we get people back for their second doses when it's 10 below zero, it's snowy, it's cold, and people don't want to travel. So giving someone just a single dose is great. The other great thing about it is it's easy to store. It can be kept in a refrigerator for up to 2 years, not like the Pfizer vaccine. And it's extremely inexpensive. We're talking a cost of about $3 a shot, versus if you look at the Moderna and the Pfizer, they're closer to $35 a shot. Johnson & Johnson can make 1 million doses by June, which is great. And they have 7 factories here in the United States that will be producing this vaccine as soon as it's approved. And you can see the 72% effective rate in the US. Many people are saying, well, why would I get the Johnson & Johnson? Matter of fact, was one of the questions. Should I wait, or should I get the Moderna or the Pfizer and kind of avoid the Johnson & Johnson? We all have to remember that the CDC set a guideline of 50%. If Johnson & Johnson were the first vaccine to come out and came out with a 72% effective rate, we would have all cheered. We thought that they would be the first one out, but they were sidelined a little bit for a couple reasons, and unfortunately got pushed back about a month. But we're all looking forward to Johnson & Johnson coming out. Novavax, on the other extreme, we thought that they would be a little bit later to the game, but actually they're doing quite well. Their phase 3 trial was completed in the UK, and now they're ready to go there. And again, it's a 2-dose vaccine. Not as effective on the South African strain, which is concerning. And the Astrazeneca strain, which we'll talk about next, is even more concerning as we talk about this. So if you look at Johnson & Johnson with 100 million doses, Novavax, if they get approved by April with 100 million, plus the other two, we will have north of 300 million doses in the United States. So one of the things I'm saying to people, be patient. The vaccines will be there. We will not run out. And it's going to be more, now it is a demand over supply. In the future, it'll be supply over demand. we will be looking for those people who were on the fence. If you go to the next slide, Astrazeneca, you probably have all heard of Astrazeneca. We thought that they would be the first to market, and unfortunately they were not, or I could say fortunately they were not. And the reason I say that is if you look, isn't the rest of the world using Astrazeneca? Well, they certainly are in the UK. The UK, they looked at it and said, you know what we're going to do? We're going to give that first dose and delay that second dose for 12 weeks because we know we get a high effective rate. What they're really trying to do there is get a broader base first dose down, which you probably heard Dr. Fauci talk about. You've heard many people talk about. The reason we're not doing that in the United States, because in the order for the time for it to be proven to be working right and to protect everyone, we will have enough vaccine. The difficult thing is that AstraZeneca has fallen flat on its face against the South African strain to a point where they stopped using it in South Africa. Still being used in the EU, mainly because the South African strain is not hit there. For us, when will we use it? We're not sure. The clinical trial that they did in the United States had a couple of faults. Matter of fact, they had an interesting one about the fault. In the study, they broke it up into two arms. One arm, they gave half a dose, and another arm, and when I say arm, I shouldn't say that because that's where people get shots. Two tracks. In one group of people, they received a half a dose of the vaccine. Another track of people received a full dose. Unfortunately, they didn't know that until after the study was done. The interesting thing was that those who got the half a dose had a higher success rate than those who got the full dose. In the United States, when we see data like that, that makes no sense, we take 2 steps back and say, we want you to repeat the study. That is why AstraZeneca is not in the market here in the United States, and its future is very unclear as far as when it will come out. They're completing the study right now, but I think this was going to be one that is going to be looked at. So we shouldn't be mad that everyone else in the world is using AstraZeneca. I think with everyone saying, did we rush to market with vaccines? The FDA and the CDC certainly has shown us that what they did with AstraZeneca was the smart thing to do and to make sure that we're going to use a safe vaccine that's effective. You can go to the next slide. So vaccines, you're confused? You're not alone. Who should get it? Right now, we are currently in Group 1B. Group 1A was nursing home individuals and healthcare workers. Group 1B now is age 65 and up, essential workers, first responders, and again, extended healthcare workers. Where do oncology patients fit? Most of them fit in 1C. If they're under 65, they fit in 1C. If they're above 65, they're in 1B. So any oncology patient 65 and up is in 1B and should be able to get a vaccine now. However, if you're under the age of 65, but you have an oncology diagnosis, you will fall into the 1C group, which don't be concerned, we will be there sooner than you know. So the big message is, like I say, be really, really, really patient right now. So you're going to say, well, who shouldn't get it? Well, one, we didn't do the study on any pediatric patients. There's 2 pediatric studies going on right now, but none of them have been completed. So we certainly shouldn't be giving it to the pediatric patients. So really, one study is those under the age of 16, one is 18. Individuals who had a severe allergic reaction in the past to anything, whether it to be shellfish or peanuts or whatever. If you had an allergic reaction called anaphylaxis, where you need an EpiPen, or you've been hospitalized, or you've been put on strong doses of steroids, we're going to ask that you hold off at this time. We're going to ask that you are going to be protected by the herd immunity of all of us getting the vaccine. Now, some individuals or some physicians say, you know what, she's too much at risk, they're too much at risk, I still want them to get the vaccine. Those individuals who had severe allergic reactions in the past who are going to be vaccinated, we want that to happen in a hospital. We don't want that to happen in a Walgreens, a CVS, a doctor's office. We want it to be there, and we will know that you've had an allergic reaction in the past, and we'll have experts standing by in case we need to interact. Leukemia patients who are right now with low blood counts, or leukemia patients who are receiving chemotherapy with swaying blood counts, again, have the discussion with your oncologist. Many of them are going to ask you to wait until your white blood cell count comes up so that you can get a good immune response. And again, recipients of stem cells in recent months are probably going to be asked to be hold off a little bit in order to make sure that you get the same response. But for the most part, everyone else, we're going to be saying that. So I also gave the Gilda's folks the NCCN guidelines for oncology patients, which I think that they shared with many of you. And you can see right there what this group of world-renowned experts is telling oncology patients, and that is to get the vaccine. You may not get the full response, but you're going to get some response, and the protection from you from this virus is very, very, very important. So someone asked about herd immunity, and herd immunity is when enough people have been either vaccinated or previously infected to force the virus to stop spreading because there aren't enough vulnerable people to affect and to continue the spread. If you look here on the left, you can see those red individuals who are not immunized and sick. And then you can see the ones that are in the blue there, immunized but still healthy. That red circle shows how far that virus is going to spread. And you can see on that side, you're still going to be spreading the illness. As you get further along to the right, where you have much more people immunized or protected, the virus doesn't have an opportunity to spread. This is Darwinism at its finest. And when you hear about the variants, you're going to understand why we have concern. Right now, we're looking at herd immunity at about 70% being vaccinated. 300 million people, we look at 210 million people needing to be vaccinated. We're certainly nowhere near that number, but we're also at about a 10% positivity rate with some protection. So we will get to herd immunity. And if you listen to the experts, which certainly I am not one of, we're looking at mid to late summer to have that possibility if we can get those people who are hesitant to take the vaccine to get off the fence and get onto the side of they're willing to take the vaccine. You can go ahead to the next slide. I'm going to tell you just quickly about a variant and how it works. And I do this just because you hear the word variant, and let's make sure we understand exactly. And I'm going to do it as simply as I can. If you look at the blue Volkswagen there, let's just say that's the original virus. And now we're going to make an antibody to that. And we're going to say, we're going to look for a blue car and we're going to look for something with 4 tires. We make that antibody, it's going to attack that. What happens now is it changes a little bit and it becomes a variant. But now the variant is yellow and it's not blue. Still has 4 tires, but it's smaller and it's easier and it can get around easier. So now you're going to look and say, wait, that's a variant, but it still has 4 tires. It's still a car. So me as the body say, you know what? It looks enough like a Volkswagen that I'm going to get an immune response to it. It may not be as strong as the blue, but I'm certainly going to make a response because it looks foreign enough to me. So antibodies won't work as well, but they still work. Go to the next slide. So the first one there would essentially be, we'll say the UK variant. Here, the world would be upside down a little bit, right? The blue car is the original virus. It's a blue car with 4 wheels, and we're looking for a blue car with 4 wheels. It now mutates and it becomes a variant. It's still a transportation vehicle, but now it's a blue airplane, and it's only got 3 wheels. So the vaccine may work a little bit because it's still looking for blue and it's still looking for wheels. But now that variant, because it can fly, can move a lot more, it can spread a lot more. So the smaller car, the airplane that can move, Darwinism at its finest, if I can spread, I can survive, especially when someone is looking for a blue Volkswagen. And then the big one, more along the lines of what we're seeing with South Africa, would be the next slide. Where again, it's a blue Volkswagen is what the original one, that's what we're looking for. That's what we taught the body to look for. It's a transportation vehicle. Boy, this one, now we're in concern. It's an airplane, so it's still a transportation vehicle, but it's not a car, it's not blue, and it has no tires. So antibodies are not going to work very well at all on that. And this is where we're going to need a booster. And this is the condition in the state we're in right now, where when the virus mutates, is it going to mutate to a smaller yellow car? Is it going to mutate to a blue airplane, or is it going to totally mutate to something it hasn't seen? Each one of those has a different impact on not only the spread, but also how the virus and the vaccine work together. You can go to the next slide. So what can we still do? Monitor for the vaccine distribution. Most of you who are listening today are going to be in either 1B or 1C. Talk to your doctor, find out how they're doing it. And if you're a Northwestern patient, you're going to get a message from my chart. If you're with advocates, you're going to get a my chart. So many of us are using that technique. So look for that when your time comes up. Grab the first vaccine you can. Don't worry about it being Johnson & Johnson, Pfizer, Moderna. You want to be vaccinated because you're going to get great protection even with that first dose. Even after that, we're going to ask you to social distance. Mask when you're out in public right now, and even after you get the vaccine, because unfortunately we haven't proven that the vaccine will prevent us from still being carriers. Many of you were asking about double masking. I'm a huge advocate of double masking. If you remember, we wore masks, a single mask we wore in order to protect others from us. In case we were asymptomatic, we wore a mask so we would not spread. Now with the double mask, it's both. It's not only going to protect you more, but it's also going to protect those around you. The beauty of the double mask also keeps the mask in place. One on top of another makes it difficult for it to slide down over your nose or up over your chin, which we see in the public all the time when those become not as effective. Soap versus gel. I'm still a fan of gel. Gel has alcohol based in it. It denatures the virus right away, and it actually kills the virus on contact. Soap, it's okay. All soap does is break down the oils on our hand, and we need to rinse those off. People have heard sing happy birthday while you're washing your hands with soap. Not many of us do that. But in fact, I can tell you, I can wash my hands with gel in just 30 seconds. I can have my hands completely clean and totally virus free. Continue to get tested if you're concerned. Be understanding as we advance the vaccine. Look out for others, be tolerant, but I think the biggest message is to be optimistic. You can go to the next slide. Many of you asked, what are the best resources? cdc.gov/coronavirus for general information is great. COVID-19 at nih.gov. There's a couple things there. One, it'll tell you the current treatment options. It'll talk about the remdesivir. You might have even seen that there's some very promising news on a couple of new medications that treat the virus within just a few days, but it'll also give you the most up-to-the-date vaccine news. Nccn.org, it's going to give you the cancer and COVID resource. That's going to be where people are going to be going saying, I have this type of cancer. Should I be getting the virus or the vaccine? And what else should I do? FDA.gov, vaccine safety education is going to be the big thing there. So it'll tell you all about the vaccine studies that have been done. And it'll also educate you. And then harvard.edu has got a great FAQ section so that anybody who has any general questions. So depending on what information you're looking for, these are probably the best resources, and I'm sure the people from Gilda's Club will share them with you. And I think I hit my time of 30 minutes. So if you can go to the next slide about learnings. We have learned that this can be spread person to person. That's why we're all being asked to wear masks. We know that all patients do not have symptoms. So we know that that asymptomatic person is there. Looking at medical data can lead to mistakes. We talked about ventilators. If you remember, I said that briefly in the beginning. Remember, we were all concerned. We have enough ventilators. We were talking about moving ventilators from state to state. And yet here in the fall, we hit twice as many patients, and yet we didn't hear one word. Why? We learned that ventilators are not good for patients with COVID. We've learned that if we put them on their stomach and give them high flow oxygen, we can actually oxygenate their lungs better than we can if they're on their back with a tube and a machine doing their breathing. So very interesting things. We've learned that good isolation can limit the spread. Talk about distancing, talk about the mitigation process that we've used here in Chicago, as well as in the schools. PPE, we've proven in the healthcare team, I can tell you our number of positive rates for our employees at Northwestern is less than the general public. And we deal with patients with COVID every day. And we talked a little bit about that. So I'm going to stop there because I think Brad and the team wanted me for 30 minutes and to give you guys an opportunity for the questions I may not have answered and any that have come up in the past few days. And I will do my best to answer any ones that you have. So I'll turn it back over to you guys.
So at this time, if anyone has any questions for Dr. Most, you can insert them in the chat, or you can even unmute yourself and you can go ahead and ask away.
Or if I said something that didn't make sense or confused you more.
Hi, doctor.
So, this is,
go ahead.
oh, I'm sorry.
No,
This is
go ahead.
Judy. Hi, doctor. I have a question. What you were saying about severe allergies and allergies to peanuts or shellfish. Why are those types of things concerning for these shots? It surprises me that it would not be like an allergy to the medication itself, but these other types of allergies.
Correct. And it's really not even those allergies. What we're concerned about is there was a very small number that had anaphylaxis after getting a vaccine. So we are saying, boy, why would we give it to somebody who's had anaphylaxis? Really, when you look at what's in the in the vaccine, there's a couple chemicals, polyethylene glycol. Probably nobody knows if they're allergic to it because it's very rare to be used, but you may be. We couldn't explain some of the allergic reactions, so we said better to be safe than sorry, so that anybody who had severe allergic reactions, we're going to try to protect them to make sure until we get more data to not put them in that place. Not that shellfish has anything to do with it or peanuts has anything to do with it. Those are the two most common allergies that can really give you severe anaphylaxis.
Okay, thank you.
Sure.
Dr. Most, we have a question in the chat. Can people get COVID more than once?
Yes, you probably heard that, just recently here. Two reasons for that. One is someone that may have gotten COVID a year ago at this time. We don't know how long their immune response is going to last. So we're certainly a little bit concerned there. And you probably heard again today talk about, will we need a COVID vaccine every year? The other concern we have is the variants. So now, if someone had the novel coronavirus and made antibodies and had a decent antibody response to it, but now have been exposed to the UK, are they going to get the same response or are they going to get somewhat ill? So we look at the blue car versus the yellow car. They still may get sick, but they may not get as sick, but it certainly looks like you can get a second infection, but very, very, very low numbers. The other thing that's encouraging is anybody who has had COVID in the past who has now gotten a vaccine has gotten 10 times the response that the person that got 2 shots. After 1 shot of the vaccine, anybody who had COVID in the past was getting 10 times the response than someone like me who got the 2 vaccines and got a normal response. That's very encouraging.
Thank you. I think we have a question from Louise.
Yes. Hi, doctor. I had the first dose. I'm actually one of those people who is allergic to polyethylene glycol. I'm allergic to Miralax. So when I took Miralax many years ago, I broke out in hives. Well, I went to UIC and I've actually had the first dose because the allergist was on site and said she felt like I could move forward. And I did, but I did get itchiness for 3 days. And I found out that in allergy medicines like Zyrtec and Allegra actually have polyethylene in it. So I went on and because I don't digest pills very well, so I took the children's Benadryl 25 mgs like an adult dose, and that helped out a lot. The question is, and they said that I could safely move on with the second dose because this was more like a mild reaction. I talked to my primary care physician and the allergist so far and the pharmacist, and they said, I should move on. I just wanted your opinion on that, or should I wait?
No. So there's two ways to look at this. One is, I'm not sure whether you got Pfizer or Moderna,
I
but
got
either
Pfizer.
way.
I got the
Okay,
Pfizer.
good. So right now, you currently, even after the first dose, if you're a week or two into it, you have protection probably about 65, 70%, we'll say. So some doctors would say, you know what, you got 70% protection. Why don't we wait? Others say you have this one opportunity to get this bump, but we don't know whether it's the opportunity at 28 days, 21 days, or it's going to be at 10 weeks. I would say that if you are going to get the second one, the biggest thing I would say is make sure you have it at the hospital. Make sure that either the allergist is there or they watch you for a good 30 minutes afterwards. And then also talk to them about preemptively taking Benadryl as soon as you get
I was thinking
vaccine.
to do that. Yeah, I was thinking to see
Yep.
if I could take the Benadryl before I actually take the vaccine. And over there, they looked at me for about over an hour. And the only thing I felt within the hour was just a little tingling of the tongue. But when I got home, I felt more itchy, just a little bit more itchy.
Yeah. So the concern often is that you may get a bigger response with the second than you did with the first. So that's probably the biggest concern I would have. So
Okay.
that's one where, again, have the conversation with your physician, but you have this opportunity to get great coverage, but we don't want to put you at harm's way. So we want to make sure that you're in a safe environment when you do it.
If I do wait, say like Johnson appears, could I actually wait that long for another kind of vaccine?
Yeah, I mean, right now there's a study going on. It's interesting. Again, we call them arms of studies, but there's a study going on right now looking at using different vaccines. Right now, if you got AstraZeneca in the UK for your first shot, we want you to get AstraZeneca for your second. Pfizer, Moderna, we want to match them up. They're doing a study right now to say, well, wait a second, what if we gave the first dose Johnson & Johnson and the second dose Moderna or Astrazeneca? So they're doing the mix and match to see if they even get a better response. Be fascinating when the results come out. For you, the AstraZeneca or the Johnson & Johnson, which again won't have the polyethylene glycol because they're going to be an adenovirus-based vaccine, would probably be much safer for you. And again, the Johnson & Johnson would be a single shot. So that may be a great discussion you want to have with them. You still have decent protection right now. It'll be interesting to see how much Johnson & Johnson comes out and where it's distributed, but that may be your best bet right there.
Thank you, Louise. I know that we do have questions with people that are using the raising hand function. I do want to get to everyone in the chat. The next question is relatable, I think, to Louise's question. I've been hearing mixed information on whether it's advisable to take ibuprofen or Tylenol just before or after getting vaccinated. Some say it helps reduce side effects. Others say it reduces efficacy and should be avoided. What is the correct answer?
Yep. So that's a question that has been asked so many times, and we wish we had the correct answer for it. I can tell you personally what I feel. The immune response, when it gets turned on, inflammation is very important to it. It shows that there is more need there. So if you take something to block inflammation before you have it, it might stunt your immune response. That's the argument that a lot of people are taking right now, and I agree with that. So I would say, and also you may not need it. I can tell you, I got 2 doses of Pfizer. I didn't take anything for them. They didn't bother me at all. Some people have different responses. So I would say that the best way to do it, the side effects are very short-lived. You may feel miserable. I mean, some people do feel miserable for a day or two, but I can tell you the protection you have, that's telling you that your immune response is really kicking in. So I personally would say, don't take anything. Some people are going to want to take some Tylenol. It's a little bit of a pain reliever. It might keep your fever down. Again, I don't want to do anything that's going to slow down the immune response. It's the exact reason why we're getting the vaccine.
Thank you. The next question, Dr. Most, would you please speak more about when we may learn about if we can spread the virus after receiving both doses of the vaccine?
Right. So when you look at the vaccine trials, and I'll try to be as simple and brief as possible, you've probably all heard about the phase 1, phase 2, phase 3 trials. When we got to the phase 3 trials for these vaccines, two things happened. A group of people, about 15,000 each of them, got saline put into their arms. 15,000 other people actually got the vaccine. In order for them to tell whether or not this was effective to stop the spread, they would have had to continually test these individuals after they got the vaccine. They declined to do that for both Moderna and Pfizer. AstraZeneca did do it. Johnson & Johnson has done it. AstraZeneca showed about 65% stopping of transmission rates, which is very reassuring. Now, I can tell you, Pfizer, as well as Moderna, are doing those studies right now because they're being very fair where everybody that they're giving a shot to now is actually getting the vaccine. It will not cloud up the data. So it's we'll know more about it, but unfortunately, it's going to take a while by the time we figure out if this is going to slow the transmission. And I guess I probably should have been a little bit more clear too. The goal of a vaccine is to stop symptoms and severe illness, hospitalizations, and deaths. That was the goal. The goal was not to totally eradicate the virus in the back of your throat or your nose. It was to make sure that the body was in check very quickly to stop the bad things from happening. That's where we're getting this 92, 95%. We unfortunately don't know. Can the virus still live in the back of your throat but not cause symptoms, as it did for a lot of people? That's why there was so much asymptomatic spread. And that's the big concern that we don't know. And that's why I still wear a mask every day to work, even though I've gotten both doses of the vaccine.
Thank you. The next question, should caregivers of stage 4 lung cancer patients get the vaccine? And how do you take care of your loved one after?
Yeah, it's an interesting point that has just been made, that caregivers now have been moved up into that 1B group. So really, hopefully that they are looking at the individuals who are caring for these individuals. Someone who is in advanced cancer, certainly you do not want them ever to possibly get COVID. So what you need to do is you need to be very, very vigilant with hand washing, with distancing as much as you can. Certainly either double masking or wearing an N95 when you're around that individual that you're caring for. So really, when we look at the oncology patients, we have to take 2 steps back also and say, who is surrounding them in their house? What can we do to protect those individuals? So not only vaccinating them early, as well as making sure that they understand the importance of PPE and the importance of the timing and distancing that has been proven to help spread this virus.
The next question, I know that you mentioned getting both shots with the same brand. How does that apply to boosters? Should the booster shot be the same brand as shot 1 and 2?
Well, the interesting thing about the boosters is it's going to be based on which variant they don't work well against. So right now, if you look at Pfizer, it's still working fairly well against the South African variant. Compare it to Astrazeneca, which has fallen flat on its face and not working well to a point where they stopped using it in South Africa. The booster there will certainly need to be for the South African variant. The booster for Johnson & Johnson or the booster for Pfizer, we're not sure. Is the UK going to make a little bit bigger impact? Is the Brazilian going to make an impact? So really what we're going to look for is you're going to look for the hole that your vaccine did not fill, and that manufacturer is going to fill that hole with the booster.
The next question, I am in active treatment for ovarian cancer and my white and red blood count are low. Can I take the vaccine?
So that's a great discussion to have with your oncologist. I have many oncology friends and I've discussed it with them. Many of them are saying, absolutely. You may not get a great response because we have to remember, this is not like Flonase where we're giving you a live virus or this. There's no live virus here. It's just turning on your immune response. Now, someone who's getting active treatment, certainly talk to your oncologist, but I would bet you that they're going to say, yes, we want you to get it. You may not get the best response, but any response right now can protect you from getting the symptoms that really are the thing that we're trying to prevent you from getting.
Are vaccine records from Walgreens and CVS shared with Northwestern Medicine for Northwestern Medicine patients?
So all vaccines for the COVID are put into a database called the iCare. And there's a couple reasons for that. One is, like I said earlier, we're using all of these vaccines under what is called emergency use authorization. So essentially, even though we're getting the vaccine right now, we're all kind of in a big trial. As soon as you get the vaccine, they're going to give you a piece of paper that says, if you have any symptoms, we would like you to log onto this website and tell us what those symptoms are. The trials were run on 30,000 people. What happens now is now we're giving it to millions. So we are really going to get more information. The iCare will certainly be pushed and should be pushed to your medical record if you have an electronic medical record with a large group. So they've already tied into iCare. That's how they got the permission to give the vaccine. So we are all iCare providers. We're allowed to give the vaccine, and therefore we collect the data and it goes into our chart.
One of the last questions in the chat, how does Northwestern determine who all the high-risk patients are, and how will the vaccine be distributed to those high-risk groups?
Right. So that's what we're going through right now. So Northwestern initially went on age, and we started, it's amazing, our first week of vaccine at Central DuPage was those over the age of 94. The oldest we gave one to was 102. So we really went by age. And then we also went by vulnerable zip codes for us to be the next layer. We found here in many areas have found as well that we have vulnerable areas. We had a lot of Latinx community where a vast majority of our cases came from, where they still had an extremely high positivity rate. So we focused on them. Your physician will be the one that's going to help you with where you stand with the comorbidities. You know, someone might say, well, I have rheumatoid arthritis. Is that a comorbidity? Not as much as someone who has asthma, heart disease, kidney disease. So we're going to have to tier those and stratify those, but it certainly is going to be also focused by age, because we really, if you look at the severe illnesses, and you know, some people are going to say over 50, but I can tell you, if you look at the severe illnesses, over the age of 65 is where we have the problem. Under the age of 65 with some other conditions are concerning as well. Probably one of the biggest concerns that we have is how we're going to deal with the obese patient. Obesity is a epidemic in this country, and unfortunately, those individuals often will not do well with COVID. So we're going to have to figure out how to highlight that population and explain to them the need to get them vaccinated as soon as possible as well.
Thank you. It looks like we've finished all the questions in the chat. I can see that Judy, your hand is still raised using the emoji if you'd like to chime in with a question.
Yeah, thank you so much. So that was my question about the high risk patients. So, you know, I have asthma, and I'm in my mid 50s. So is there an algorithm that Northwestern is using, and are they somehow tying into a patient's MyChart to pull diagnoses and sorting, like, you know, by diagnosis, or
Gotcha.
how are they
No.
finding that out?
Well, we're using age right now because we're still in the 1Bs. So we're still looking
Right.
at everyone over the age of 65. The question that we need to hear, or I shouldn't say the question, we want to make sure that there's not only transparency, but parity. So we want to make sure that everyone is treated on an equal basis here. And it's not only Northwestern. We're looking for input from the federal government, the state government. You know, you can have asthma and have a normal, you know, peak expiratory flow. And then you can have asthma and really be suffering. So there's a big spectrum of asthma. There's a big spectrum of diabetes. So we're looking at it saying, help us a little bit, give us some objective measures and tell us what to do. Because if not, we have age and physicians that are now going to be put into a position to say, here's your 1,000 patients that are in your practice. You stratify those for us. So really what we're looking at, tell us as much data as you can as far as, should we be more concerned about patients with congestive heart failure? Or should we be concerned about patients with asthma? Or should we be concerned about patients that are obese? We don't know the answer to that. So right now we're going, let's get age cooking because we know that number, and let's try to get as many shots in arms as we possibly can as soon as we can.
Okay.
Look-
So the primary care doctors and the various specialists really do not have input into this for high risk people.
They don't yet at this point. The logistics of that are something that we're all trying to figure out. And right now it's much easier.
Okay.
The other thing I guess that's a little bit frustrating to us as well is you also have to remember that in the 1B group, we have essential workers. So we're looking at it saying, well, wait a second. Do we want to vaccinate the 18-year-old or the 20-year-old who works at Mariano's? Or do we want to worry about the 55-year-old who has asthma? So we're still trying to figure out that because 1B includes restaurant workers, teachers, police officers, transportation. So we're looking at, boy, should we be focused on occupation? And we're saying, you know what? We're going to make us as efficient as possible and work from age and get down and get as many shots in arms as we possibly can, as quick as we can.
I see. Thank you very much.
Sure.
Thank you, Judy. It looks like Erica, I think you have your hand raised.
I do. Thank you for tonight's session. Thank you, Dr. Most, for answering a question regarding caregivers and lung cancer and the vaccine. I'm still not clear on which, and if you don't have the answer, that's fine, but which would be the greater risk, you know, getting the vaccine and that autoimmune response, you know, while you're such an advanced stage of the cancer or possibly getting the disease. And then also the fact that, you know, if you have patients who have already pre-existing to cancer autoimmune issues, like in my mother's case, she has scleroderma and that whole CREST syndrome. So it just feels like it's so many things going on to then put something else in the system.
Yep, 100%. Yeah, no, totally. And this is one where many clinicians say, I wish we had 10 years of data. I wish we had 15 years of data. And for those individuals, we're saying, we're almost treating them like the allergic patients. We're saying, hey, you know what? Protect yourself. Do what you're continuing to do right now around yourself. Let's try to get everyone else vaccinated around you. And you're going to be part of that herd immunity because we don't want to give you something that we can't predict what might happen to you. You know, the healthy, semi-healthy person who really can handle any vaccine, that's great. But individuals who are kind of on the fence right there, we're saying, you know what? If we get more people vaccinated, the few that don't, we're still going to be able to protect them. And I think you're going to see that's where some of the hesitancy comes in, saying, I'm not so sure about this. I'm going to continue to what I'm doing to protect myself while others get vaccinated around me.
Okay.
Thank you.
So then if I did choose to get the immunization myself, I need to then mask up and wear gloves or just really try to have somebody else act as caregiver and give myself some time away from my mother, the patient.
Well, I think that even if you get vaccinated, we still have that uncertainty of will you be an asymptomatic carrier? So until we know the answer to that, you're still going to mask up when you're around your mother. Absolutely.
Okay. Okay.
Yep.
Thank you.
Sure.
I just want, thank you. I just want to be mindful of time. We still have about 7 more minutes. I also want to let everyone know that Dr. Most has graciously offered for us to share his slides. So we'll be sending those at the end of this lecture or tomorrow. If anyone has any other questions, can you please go ahead and either use the raising hand function or chime in if you have a question, please. Looks like Lisa unmuted herself. Maybe Lisa, do you have a question?
No.
Okay. Anyone else? Any other questions?
Ashley, I'm going to jump in here if I can. Kev,
Okay.
the 92, you talked a little bit about the 95% versus the 72, but the important thing for J&J, the other part that I don't know that you touched on is it's really highly effective in keeping people out of hospitals and the more severe reactions. Is that true?
Yeah, absolutely. And you make a very good point. When we look at the J&J and people are saying, no, 72%, but they also had no severe hospitalization and no deaths, which is better than the other vaccines have. And the other thing about Johnson & Johnson is they're actually running a parallel study right now for the second shot. So Johnson & Johnson may come out here in a month and say, you know what, we have a second shot that actually increased us from 72 to 90%, which would not surprise me when you look at what happened with Pfizer and Moderna. So although people like Brad said, although people are looking at that 72%, look at the end game, and the end game being no severe hospitalizations, no deaths from Johnson & Johnson, which is something the others can't tout. They did have some severe hospitalizations, they did have some deaths. So although you might look at those numbers and say, boy, I'm going to stay away from Johnson & Johnson, I would say, don't stay away from it, and also follow it, because they may come up with a booster right after it that shows that they got to market in a right way and they did it in the right way, and are going to show that their booster shot will actually get them up to that 95% while still protecting you now.
Okay.
Question, so how will I be able to get a hold of a Johnson & Johnson? It seemed like they're just giving these vaccines and whatever's available. How will I be able to make for sure I could get Johnson & Johnson?
You don't. So right now, it's Johnson & Johnson hasn't even been released. So we really expect probably the first dose of Johnson & Johnson to be released probably right at the end of February. Now, no one is going to say this is the vaccine that you're going to get today until probably the middle of the summer, where you might have an option. Because right now, I can tell you what we get. We gave 1,000 shots today. Whatever we had, we're using, because we know that how well each of them is working. I think that Johnson & Johnson, I think a couple things you're going to see. You may see them go to more rural areas because it's much easier handled than the Pfizer and the Moderna. Doesn't need some of the expertise to storage. So I think you might see that into rural areas, and potentially, I guess you would see it in doctors' offices as well, where the hospitals will continue that have the ultra cold freezers to take care of the Pfizer doses.
Maybe I might have to wait till June then.
Well, again, based on ages, it really, by the time we get to 1C, I think you will see a lot of Johnson & Johnson out. I think you'll start to see a lot of them out. And at that point, you may be able to shop around, but I would say if you start to see the numbers start to creep up like we are expecting that they may with the UK variant, I would get the vaccine as soon as I could, regardless of the manufacturer. There's only one that I'm a little bit concerned
I'm the one that has that
Astrazeneca.
allergy. I'm the one who has that allergy.
Oh,
Yeah.
If you're the one with the allergy, yes, you should be looking for the Johnson & Johnson. Yep.
Yeah, okay.
So again, just want to be mindful of time. I think we have one more question from Judy.
Yes, doctor, for individuals who are adrenal insufficient, do you have any opinion on whether or not a stress dose is required for getting this vaccine?
Again, the small population of those that are adrenal insufficient and the steroids that, are we concerned about that in the immune response? I'm not, that's probably a great question for your endocrinologist. I would not be an expert to give you a judgment either way, although I would bet you that they would say, I would bet you that they're going to say, don't worry about it and go. That would be my gut.
Thank you.
Yep.
Okay, thanks. And thank you so much for the presentation today. It was really informative and outstanding information. Thank you so much.
Oh, you're welcome.
Thank you, Judy. Yes, there are lots of comments in the chat box currently just saying how informative, informational, and interesting this presentation is. So thank you so much for your time, Dr. Most.
Well, I appreciate the opportunity. I love what you guys do. Obviously, my brother works with you, but what you guys do every day, and I can tell you all the people on the phone that all the people at Gilda's Club miss you guys and want to get back into real life situations and in person. But just looking at the breadth of what you guys are offering to your clients and your patients is outstanding. So it's the least I can do to kind of jump in for an hour every so often and answer any questions you may have.
Thank you so much for your time and your expertise tonight.
You are more than welcome, and we will, you know what, I would say we'll do it again, but I'm kind of hoping we don't have to do it again.
Right.
Well,
Yeah.
let's talk
Yeah.
about something else
Let's
next
not
time.
do it again.
Yeah, let's not do it again. Let's talk about something else.
All right. Well, thank you so much, everyone,
Thank you.
for attending tonight. Thank you again to Dr. Most. We hope to see you in further programming and hopefully not at this talk again.
There you go.
Thank you very much. Excellent.
Thank you.
Thanks so much.
Stay healthy.
Take care.
Stay
Thanks, Deb.
healthy.
Thanks, everybody.
Have a great night, everyone.
Thank you.
Take care.